My name is Neville Hacker and I have been running the Gynecological Cancer Centre at the Royal Hospital for Women in Sydney since 1986. One of my major objectives when I came to Sydney was to set up a multidisciplinary team, and we managed over the next few years to attract experts in all of the necessary fields in order to treat these patients appropriately. I've always had a strong interest in vulvar cancer and a more conservative approach to vulvar cancer, and we recently published our results of about 120 patients who we treated with stage 1B, FIGO stage 1B carcinoma of the vulva. And the 5-year survival was 95%, and pleasingly only 4% of those patients required a radical vulvectomy. Our focus has always been on the individual patient, and we have a multidisciplinary team meeting once a week. Each inpatient is discussed. We have a lot of expertise in various disciplines around that meeting, and each participant brings their own passion, and this passion and discussion helps to resolve often very complex problems.
So at the Royal Hospital for Women we have 2 accredited training positions. We usually take 1 trainee from Australia or New Zealand who participates in our usual gynecological training program over 3 years. We also make an effort to take an overseas person, particularly trainees from developing countries, to learn the techniques, the surgical techniques, and how we look after women with gynecological cancer here in our unit in Australia. So at the Royal Hospital for Women we benefit from having 2 accredited trainees. Our own trainees are of a very high standard, and the overseas trainees teach us to be very culturally diverse, and so it's a mutual arrangement, and we benefit by having them teach us how they would manage cases overseas in a different environment, and they take back with them some of the surgical and clinical skills they otherwise would not have learnt in their own country.
Radiation oncology is a very important part of a gynecological oncology service. We use radiotherapy in many patients, sometimes after surgery, sometimes on its own as a definitive treatment, or in combination with chemotherapy. Some patients in fact have all 3 modalities of treatment. So one of the things that we do slightly differently here from many gynecological oncology centres is we make more use of a combination of surgery and radiotherapy for stage 1B cervix cancer. The traditional teaching has been that you should try to use one modality or the other to avoid the complications of both. However, here we've had very good results using surgery for the larger stage 1Bs and then following that with small field radiotherapy rather than the traditional large post-operative fields. As you can see here, on the left is a standard post-operative field. However, if the patients had the pelvic lymph nodes removed and they were clear, there's really no need to treat that area. And so we now use a small central pelvic field. As you can see, most of the bowel is no longer in the field, but you're just covering the central region where you're most concerned about disease recurrence. And this is very well tolerated, both acutely and in the long term. One of the things we're putting into our new cancer centre is a research MRI facility, so we'll be able to use MRI much more for planning the volumes of cervix brachytherapy. And as you can see, the imaging on brachytherapy with MRI is much better than with CT.
We have been very much at the cutting edge of research in gynecological oncology in Australia at the Royal Hospital for Women. I was the founder and initial chair of the Australia-New Zealand Gynecological Oncology Group. We've been running clinical trials here from the day I started, and these are cutting-edge trials that really changed the way that we manage women with ovarian cancer specifically, but also other gynecological cancer types. And at the moment we're focusing mainly in PARP inhibitors and in immune checkpoint inhibitors.
There is a strong culture for nursing research in the department, and this is very well supported by Professor Hacker and by nursing administration. So most recently, a part of my PhD research has been looking at the trends in incidence and mortality for vulvar cancer in Australia over the last 30 years. And overall we found that there's been an increasing incidence in vulvar cancer for women under 60 years of age, and this is probably most attributable to their exposure to the human papillomavirus since the 1950s. We are also looking at the presence of p53 mutations in squamous cell carcinoma of the vulva, and this immunohistochemical profile may be beneficial in determining disease progression and prognosis in the individual patient with vulvar cancer.
Women that have gynecological cancer suffer a lot of side effects from their surgery and their treatments, that being radiation and chemo. And these are the sorts of things that I deal with and help them with. A lot of that is anxiety and depression. And one of the biggest problems I find is fertility, because we do have very young women come in here as well who've got to have all their reproductive organs removed, and therefore they can't have children. And that often causes the most extraordinary grief. So I do spend a lot of time with those sorts of problems in women. I think the uniqueness of this centre is that we are able to actually diagnose patients, treat patients, and take them right through to maybe palliative care. And we do all that under the same roof. And I feel quite privileged that I'm involved in that care, that long-term care.
The most challenging cancer that we treat is ovarian cancer, and so for the last 15 or 20 years we've had a basic research program aimed at trying to find a screening test, a marker, or more likely a panel of markers that would allow population screening. This is really the holy grail of gynecological cancer research, to discover a screening test for ovarian cancer. Uniquely, I guess one of our major interests has been in the surgical management of the stage 1B2 cervical cancer. These are the big cancers confined to the cervix. And two of the cases that we reported were actually pregnant at the time, and they had radical caesarean hysterectomies. But more recently, we had a young woman, Lisa, who elected not to have the surgery, although she had a very large 1B2 cervical cancer at about 18 to 19 weeks. We got Michael Friedlander involved, and she had some chemotherapy and had a remarkably good response to the chemotherapy. And she subsequently had a successful caesarean radical hysterectomy, and the baby's doing very well.
So I guess in a nutshell, the hospital staff were just outstanding, and we couldn't fault it, going from oncology to birthing suite, and you know, from the reception staff and the professors and every single person that I have ever met here and continue to meet and catch up with on the outside world. It's like another life. Like, I feel like royalty when I'm here, and I'm just so ever grateful that I stepped foot in this hospital. Yeah, I really am.